Great, well, welcome. Good afternoon again, everybody. And welcome again to the STI Expert Hour webinar called Doxycycline Post-Exposure Prophylaxis, Promise, Opportunities, and Considerations for Implementation. My name is Dr. Kelly Johnson. I'm the Medical Director for the California Prevention Training Center. I'll be emceeing today's webinar and going over some introductory slides. I'm going to go off camera to do that, and I'll come back at the end for the Q&A. So first, just to tell you a little bit about the California Prevention Training Center, or CAPTC. CAPTC is a multidisciplinary training and capacity building assistance center. Our STI clinical training is sponsored by the CDC, and we're a member of the National Network of STD Clinical Prevention Training Centers, or NNPTC. Our STI clinical training provides virtual and in-person training events, technical assistance, clinical tools, and STI clinical consultation services focusing on complex issues in STI patient care. You can learn more about STI clinical training at CAPTC and the NNPTC by visiting the web pages listed on this slide. The CAPTC also runs the STD Clinical Consultation Network, or STD-CCN, for our region. This is an online clinical consultation network where providers can submit complex STI questions, and a subject matter expert will reply either by phone or email per your request within 1 to 5 business days. Here's our financial disclosure for today. We have nothing to disclose. And here's our CME disclosure stating that today's webinar is offered at 1.25 units. Here are the CME requirements to earn those 1.25 units. So first, you must have registered for the webinar on the NNPTC site by the deadline. Please note that registration is now closed. You'll need to stick with us for the full webinar today by watching it again live and in full. Unfortunately, we can't give CME credit to those viewing a recording of this webinar. We also can't give partial credit for viewing just a portion of the webinar. Attendance will be noted as attendees sign on to the webinar. You will also need to complete the post-course survey evaluation by the deadline of May 5th, 2023. Those registered on the NNPTC site for the webinar will receive an email notification from training@nnptc.org with the link to the post-course survey evaluation within 24 hours following the end of today's webinar. The notification is sent to the same email address you used to register for this webinar on NNPTC's site. And to ensure you receive the notification, you can add training@nnptc.org to your safe and trusted senders list. Please also check your spam and junk boxes if you don't see this email in your main inbox. CAPTC's CME provider is the University of Nevada, Reno School of Medicine, or UNR. If you meet CME requirements, you'll receive notification from captc@ucsf.edu within 4 to 6 weeks from the post-course survey evaluation deadline. And this email will have a link to claim your certificate from UNR. The email notification is sent to the same email address again where you used to register for the webinar on the NNPTC site. To ensure you receive this notification, please add captc@ucsf.edu also to your safe and trusted senders list, and be sure to check your spam and junk folders if you don't see this notification in your inbox. Okay, a couple of quick housekeeping notes about Zoom. Q&A will be turned on for attendees. Microphone, video, and chat, however, will be turned off for attendees. Only presenters will have access to microphone and video. To use the Q&A, click on the Q&A icon as seen here in the middle of this slide, which will be in the bottom of your Zoom screen. Once you click on the Q&A icon, you can type in your questions and click Send to submit. If you want to send anonymously, you can select Anonymous. You can submit your questions up to the last 2 minutes of the Q&A session. Also during the webinar, I'll be reviewing the Q&A, and I may answer some of your questions directly, or they may be answered live during the Q&A session. You can also submit any administrative questions into the Q&A, and they'll be answered by our clinical administrative team of Elizabeth Olson and Lauren Blakely. If you have any questions, you can reach out to Elizabeth Olson, who is our CAPTC Clinical Program Manager. Her email address is shown here. All right, and now I'd like to take a moment to introduce our speaker for today's webinar, Dr. Stephanie Cohen. Dr. Cohen is the STD controller for San Francisco and the medical director of San Francisco City Clinic. She's an assistant professor at UCSF in the Division of Infectious Diseases and an HIV primary care provider. Her research focuses on using implementation science to guide the translation of STI and HIV prevention research into clinical and public health practice. She is currently site PI for a randomized control study of doxycycline post-exposure prophylaxis to prevent STIs. She's a passionate advocate for PrEP and loves to talk about syphilis. She's also a personal mentor of mine who I'm very grateful to have worked with for many years. And so I'm very, very excited to have her here today to speak with us. And with that, I will turn it over to you, Dr. Cohen.
Good afternoon, everyone. Thank you so much, Dr. Johnson, for the kind introduction. Thank you to Elizabeth and the California PTC for the opportunity to speak with all of you today on the topic of doxycycline post-exposure prophylaxis. I know there's a lot of interest in this new emerging tool in STI prevention, and it's really my honor to have the opportunity to share a little bit about this topic with all of you today. Dr. Johnson, I assume my slides are visible and
yes, they're visible and everything looks good.
Okay, great. Well, thank you again. So to protect computer bandwidth, I'll stay off camera for the talk and come back on at the end. To begin, as Dr. Johnson described, I have been honored to be part of the DoxyPEP study team and have been a site PI of our study at San Francisco City Clinic. Related to our study, the doxycycline for our study was provided by Maine Pharmaceuticals, and we received laboratory support from Cepheid and Hologic. And the views I'll be sharing today do not necessarily reflect the official policies of the city and county of San Francisco or the San Francisco Department of Public Health. By the end of this presentation, our hope is that you will be familiar and able to summarize data from recent studies exploring the use of doxyPEP to prevent bacterial STIs, and that together we'll be able to think through and explore implications of and strategies for implementing doxyPEP in clinical settings. As all of you on this call know, the United States is experiencing steep and sustained increases in rates of sexually transmitted infections. These national data from the CDC from 2021 show that since 2017, we have seen a 28% increase in gonorrhea, a 74% increase in syphilis, and a 203% increase in congenital syphilis cases. STIs, as you know, can cause significant morbidity in our patients, and left untreated can increase the risk of acquisition and transmission of HIV and lead to infertility and chronic pelvic pain. We also know that the global epidemic of sexually transmitted infections disproportionately impacts men who have sex with men, as well as transgender women. The top two figures on this slide of rates of gonorrhea and chlamydia in MSM are local data from San Francisco. The blue line at the top of those figures shows the rate in MSM, and the green and orange lines at the very bottom of those graphs are other men and women. So you can see in San Francisco how disproportionately MSM are impacted. And this trend really is seen in many large jurisdictions in the US. The bottom figure is from the CDC and shows again the disproportionate impact of syphilis on MSM. We unfortunately don't have as much national data as we would like on rates of STIs in trans people, including trans men and trans women, but I did want to share here just to again highlight that trans women are also disproportionately impacted by STIs. And over the last 6-7 years in San Francisco, we've seen rising rates of gonorrhea in trans women. And these trends, these increases, year upon year increases in STIs have been happening while at the same time, the number of new HIV diagnoses and HIV rates have been declining in San Francisco. And we know that this epidemiologic divide has now been going on for 8 or 9 years. And we really think it reflects the fact that we have highly effective biomedical prevention tools for HIV, including HIV PrEP and treatment as prevention. And we have not had those same types of innovations for the prevention of bacterial STIs. So there has been some interest for some time now in developing a biomedical prevention tool to prevent bacterial STIs. So with that, over the last several years, there have been a number of randomized controlled trials looking at the effectiveness of doxycycline post-exposure prophylaxis to prevent bacterial STIs. So why Doxy? Why is that the antibiotic that we've been looking at for STI prevention? So first off, doxycycline is safe, well-tolerated, and very inexpensive. We have, many decades of using Doxy routinely, so have a very good understanding of its safety profile. And we now have 3 randomized controlled trials, the IBERGAY study, the DoxyPEP study, which is the one I have been a part of, as well as the DoxyVac study, that have demonstrated the efficacy of DoxyPEP in preventing bacterial STIs and MSM. Now, all of this said, there are some concerns about this tool, and we'll dive into these more later in the talk, but they include the fact that we have not had an RCT that has shown the effectiveness of DoxyPEP in cis women. And in fact, the one RCT that did enroll cis women, the D-PEP study in Kenya, did not show an effect. We also have concerns that DoxyPEP could potentially increase the prevalence of tetracycline or doxycycline resistant gonorrhea. Now, there already is quite a bit of tetracycline resistant gonorrhea circulating, about 20% in the US, and Doxy is not a first-line treatment for gonorrhea. In addition, there's questions and concerns about the impact of DoxyPEP or intermittent doxy use on antibiotic resistance, both in STIs as well as in non-STI pathogens. And there's questions about the long-term impact on the microbiome. So what I'm going to do now over the next first portion of this talk is really go through what are the data that I'm referring to here and what do we know about the effectiveness and potential risks of DoxyPEP. So this table, again, just to orient you to the studies I'll be talking about, summarizes the key characteristics of the 3 most recently conducted RCTs of DoxyPEP. DoxyPEP and DoxyVac are quite similar in design. DoxyPEP was conducted in the United States, in San Francisco and Seattle, DoxyVac in France. Both studies focused on people who were male sex at birth. In the DoxyPEP study, we enrolled people both living with HIV as well as people on PrEP who had had at least 1 bacterial STI in the last 12 months. And in the DoxyVac study, they focused on HIV negative MSM on PrEP, again, who had had an STI in the last 12 months. The D-PEP study conducted in Kenya is the first and only study of DoxyPEP in cis women. All of these were randomized open label studies, so participants knew which arm they were in. They were not placebo controlled. And the DoxyVac study had a unique twist in that, in addition to looking at the effectiveness of doxycycline post-exposure prophylaxis, they used a 2x2 factorial design to also look at the effectiveness of the 4C Men B, or Neisseria meningitis type B vaccine for gonorrhea prevention. In all of these studies, participants were seen every 3 months and had gonorrhea, chlamydia, and syphilis testing. And the primary endpoints were similar, but slightly different between the 3 studies, either looking at time to first sexually transmitted infection or % of visits at which a participant had an STI. And in the last row of this table, you can see that the size of the studies was pretty comparable approximately 500 people enrolled in each trial. So I'm going to start by going through the results of the DoxyPEP study. And I won't do quite as deep of a dive into DoxyVac and D-PEP, but I really want you all to be grounded in the data. So here for the DoxyPEP study, as I showed on the in the prior table, we had enrolled 501 participants who were eligible for the primary analysis. 327 were on PrEP and 174 were people living with HIV. And you can see that while our study was open to both MSM and trans women, the majority of our participants were MSM. And the most of our participants had had a median of 9 sexual partners in the prior 3 months. So this was a population who had a higher number of sexual partners. Okay, and this figure shows the primary endpoint of the DoxyPEP study, which it was the proportion of quarterly visits at which an STI was diagnosed. And overarching here, if you look at the table summarizing the results, I know there's a lot of colors on this slide, you can see that doxycycline, 200 milligrams taken after condomless sex, reduced the incidence of gonorrhea, chlamydia, and syphilis by approximately 65% per quarter among MSM and trans women who are enrolled in this study. And you can see here that we analyzed the PrEP cohort and the people living with HIV cohort separately, and the results were very similar in people on PrEP and in people living with HIV. Here you can see the results broken down by STI. So the top part of the figure shows the proportion of visits at which gonorrhea was diagnosed versus chlamydia versus syphilis. And again, you can see that there was a significant reduction in all 3 of these STIs in both people on PrEP and people living with HIV, with the exception that for syphilis, because of small numbers, the confidence interval here spanned 1, so the p-value was over 0.05. And then lastly here, this is from the recently published New England Journal of Medicine paper on the DoxyPEP study. And this is a Kaplan-Meier curve showing time to first STI, slightly different way of looking at this than percent of quarterly visits at which an STI was diagnosed, but the overarching summary here is the same. The risk reduction here, the hazard ratio was 0.34. So again, about a 65% reduction in time to first STI. So quite exciting results as we've been looking, as I've said, for new effective tools for STI prevention for so long. So in terms of sexual behavior, adherence, and antibiotic use, again, you can see that our participants had a median of 9 sexual partners. This was in the prior 3 months, sorry for the typo there, at enrollment. And during the study reported about 5 sexual acts per month, 90% of which were condomless. And there was no significant change in sexual behavior during follow-up in the DoxyPEP arm in the analyses that we've done to date. In terms of adherence to DoxyPEP, 86% of people in the DoxyPEP arm reported that they use DoxyPEP always or often after anal or vaginal sex. And participants reported taking a median of 4 doses of DoxyPEP per month, with 25% reporting 10 or more doses per month. And that was based on self-report at a quarterly interview. Lastly, we found that ceftriaxone use was 50% less in the DoxyPEP arm, which again is, I think, an important benefit of DoxyPEP because we're able to reduce the use of broader spectrum antibiotics by decreasing the amount of STIs that folks get. So moving on, I'm going to quickly summarize the highlights of the DoxyVac study. So again, pretty similar. This was conducted in France, MSM on PrEP, followed every 3 months. And this was the study that included 2 interventions, in a factorial design, so DoxyPEP and the Neisseria meningitidis type B vaccine. So when you do a factorial design, that means you randomize people twice. So some people got DoxyPEP and the vaccine, some got only DoxyPEP or only the vaccine, and some people got neither, received neither intervention. So here again, you see the primary results of the DoxyVac study, which were time to first chlamydia or syphilis infection. They did not look at time to first gonorrhea infection as a primary endpoint because the prevalence of tetracycline resistant gonorrhea in France is quite high at baseline. And so their hypothesis going into the study was that DoxyPEP wouldn't necessarily be effective against gonorrhea. And in fact, in an earlier study in France, they did not find an impact of DoxyPEP on gonorrhea. So they were really focused in their study on looking at time to first chlamydia or syphilis. And what you see here again is that there was a significant decrease in chlamydia or syphilis in those on DoxyPEP with about a 84% reduction in risk. So very impressive findings and similar to what was seen in the DoxyPEP study. There was no interaction between DoxyPEP and the 4C Men-B vaccine, which essentially means the protective benefits of these were additive. There wasn't a interaction or a synergistic effect. Here you see the time to first gonorrhea and Mycoplasma genitalium infection in the DoxyVac study. And surprisingly, and contrary to what the investigators hypothesized, they did see a protective benefit for DoxyPEP against gonorrhea with a reduction in time to first GC of a hazard ratio here of 0.49. So reduction in risk of about 51%. And they also found that there was a reduction in there was a longer time to first Mycoplasma genitalium infection in those taking DoxyPEP. So very interesting results. I'm not going to spend a lot of time on the Neisseria meningitidis B vaccine, but I do want to mention it because it's certainly a very exciting finding and one that really warrants further investigation. And what I'm showing here is that the Neisseria meningitis B vaccine did increase the incidence of gonorrhea in those who received it. So you can see here the adjusted incidence rate ratio for those who received the vaccine was 0.66. Lastly, the very disappointing results of the D-PEP Kenya trial. So, I think there was great optimism about the potential for DoxyPEP preventing STIs in women. We know that women do experience significant morbidity from STIs. And this trial, again, was conducted in Kenya. The study population here was between the ages of 18 and 30. 18% of the women enrolled had an STI at enrollment. And I don't think I mentioned or highlighted this before, but all of the women in this study were on daily oral HIV pre-exposure prophylaxis. The annual incidence of STIs during the study was 27%, and there was no reduction in time to first STI for those on DoxyPEP. So you can see here on these Kaplan-Meier curves that the blue and the red lines are exactly the same. There's no separation, which is what we want to see. We want to see a longer time to first STI in those taking DoxyPEP. So what happened in the D-PEP Kenya study? Why was DoxyPEP not effective for STI prevention? So I think this is a critical unanswered question, and there's a lot more investigation to do to try to unpack this. One theory is that endocervical tissue may differ from urethral, rectal, and pharyngeal tissue. There have been some small PK studies looking at drug levels, and it does appear that doxycycline reaches adequate levels in the cervicovaginal tissue, but perhaps there's something related to like the way that pathogens adhere to these tissues. It's unclear. It's possible there's something related to the exposures, that the type and frequency of exposures may differ in the very high prevalence setting where the D-PEP study was conducted. There could be potentially issues related to antimicrobial resistance. However, to date, there have been no known cases of resistant chlamydia. And then lastly, I think there are concerns around adherence. Do we know that the women in the trial who were randomized to take DoxyPEP were taking it? Certainly in the field of HIV PrEP, the early studies of daily oral HIV PrEP in women did not show efficacy, and later studies determined that that was largely driven by adherence. So it's certainly a concern. That said, the DoxyPEP study was open label, so people knew they were getting DoxyPEP. They were already taking daily oral PrEP, so they were experienced with pill taking. There were no HIV infections at all in the study, and there was quite a bit of adherence support. So I think this is a possibility, but we just don't know yet. So I'm now going to move on to review what's known about the impact of DoxyPEP on antimicrobial resistance, because I hope summarized that what we know about effectiveness, which is that it is quite effective, not 100%, but quite effective at reducing gonorrhea, chlamydia, and syphilis in MSM, as well as in a small number of trans women enrolled in the DoxyPEP study. So shifting to AMR, there's a lot of questions about DoxyPEP and antimicrobial resistance. And I've summarized here on this slide the pathogens and as well as the microbiome, which is a lot of different organisms, where there are considerations about the impacts of DoxyPEP. So before I dive into the data, let me further frame this for you. So first of all, there's gonorrhea. So how do we test? So what I want to do is explain how we test for antimicrobial resistance in these organisms in the research context. So for gonorrhea in the United States, we are fortunate to have CDC supported surveillance systems to monitor the prevalence of antimicrobial resistance GC, and those projects are called SURGE, Strengthening US Response to Gonorrhea, as well as a network of laboratories called the ARLN labs. So in our study, the DoxyPEP study, participants who were diagnosed with gonorrhea had a specimen collected for culture, and that culture was sent to these labs for antibiotic susceptibility testing. Chlamydia, very difficult to do. Chlamydia is hard to grow in culture, but in this study, we are collecting swabs for chlamydia culture and attempting to do susceptibility testing. Syphilis, you may know, basically almost impossible to grow, grows in rabbits. So there's an exploratory analysis looking at molecular tetracycline resistance markers in syphilis. MGENT analyses are ongoing. And then in these studies, we have also been looking at the antibiotic susceptibility results for Staph aureus and commensal Neisseria. Gut microbiome analyses are very complex, but the types of things you can look at are change in flora, diversity of flora, and prevalence of tetracycline resistance genes. So moving through these, and we do not yet have data on all of these, so I'm going to focus on gonorrhea and Staph aureus and commensal Neisseria. So first off, what happened to GC? So these data from the DoxyPEP study show the prevalence of tetracycline resistance at baseline and then in incident gonorrhea in the standard of care arm versus the DoxyPEP arm. And the orange bottom sections of these bar graphs are GC strains that were not resistant. The light blue had resistance as defined by having an MIC greater than or equal to 2 versus the dark blue, which is high level resistance. And I think, first of all, I want to point out that GC culture is difficult. And out of 320 episodes of GC, we only had antibiotic susceptibility data on 56 of those cases. So our numbers are still small. But overall, the tetracycline resistance during follow-up in the doxyPEP arm was similar to the prevalence of tetracycline resistant GC at baseline. Now, if you compare standard of care to doxyPEP, you see that there was a higher proportion of tetracycline resistance amongst GC cases that occurred in the doxyPEP arm. And we think this may be because doxyPEP is less protective against gonorrhea strains that already have tetracycline resistance. I will say, although I'm not going to show data on this, that fairly similar findings were shown in the DoxyVac study for gonorrhea. Next, I'm going to talk about Staph aureus and commensal neisseria. So here you see, again, comparing standard of care in doxyPEP, the proportion of participants who were colonized with Staph aureus in their nares at baseline at month 6 and at month 12. And if you look within the doxyPEP group, you can see that 44% of participants were colonized with Staph aureus at baseline, compared with approximately 30% at 6 and 12 months. So this is about a 14% decline, absolute decline in the proportion of participants who were colonized with Staph. Now here you see, okay, so we know there was a 14% decline in the proportion who were colonized with Staph. If you were colonized with Staph, was it doxycycline resistant? So again, at baseline, 10% of participants in the standard of care arm had tetracycline resistant Staph aureus, compared with 5% in the doxyPEP arm. And during follow-up, that went up in the doxyPEP arm, an 8% absolute increase in resistance in the doxyPEP arm. So I have, again, portrayed to you kind of what we know so far with about 9 months or so of follow-up and relatively small numbers of cultures. What we are still working on are the data looking at the impact of doxyPEP on chlamydia, syphilis, and gent in the gut microbiome. So will be more to come on that in the coming months. I do want to comment on this question of the microbiome, because there are many experts in the microbiome who are collaborators in this research and who are have proposed some frameworks for thinking about the impact of doxyPEP on the microbiome. And I want to highlight some of these points here. So the first is that changes in the microbiome are expected with doxyPEP. We know that they will occur, and they might be amplified among people who use doxyPEP more frequently. But to really understand what these changes are and what their clinical significance of requires very large, very expensive, complex studies. And while we know that changes will happen, we really don't know whether they will be harmful. There's hypotheses about how the microbiome may or may not contribute to weight gain, mucosal immunity, but they're largely theoretical. And we have to really carefully consider these potential effects and weigh those against what we know are the significant effectiveness of doxyPEP for STI prevention. So this is a complex area, and there's certainly really more work to be done here. And lastly, before I move on to talking about implementation, I want to make sure that we contextualize all of these questions about antimicrobial resistance in the context of the broader way in which doxycycline is used, both as a antibiotic that's used in humans as well as in livestock. So for context, Tetracycline, there's about 25 million prescriptions of tetracyclines, the class of antibiotics, every year in the United States, and about 21.7 million of those are doxycycline. Doxycycline is one of the most commonly used antibiotics in livestock, and it is about 66% of antibiotics used in livestock. And in 2020, there were 4 million kilograms of doxycycline used, or tetracyclines used in animal husbandry. So I think it's really important to consider that doxycycline as STI post-exposure prophylaxis will really be a fraction of the total doxycycline that's used in this country. And so there's many potential drivers of AMR that should be considered. And we want to limit unnecessary use in any circumstance where we can. So with all of these exciting data, San Francisco Department of Public Health released interim guidelines for DoxyPEP in October of 2022. And these guidelines were released as we knew that there were many San Franciscans who were already using DoxyPEP. There were providers who were prescribing it on a case-by-case basis. The results of the DoxyPEP study had been presented at the AIDS conference in July. And we felt like it was important to have guidance for our community and for our providers on how to safely use this very exciting tool. So we convened a group of scientists and community members and experts to talk through this guidance. And one of the most challenging questions that we faced in developing our DoxyPEP guidelines is the question of who should be offered DoxyPEP. So as I've talked through in the DoxyPEP study, we enrolled people who were MSM or trans women who'd had at least one bacterial STI in the last year. And that's kind of an anchor, right, for thinking about who might benefit from DoxyPEP. In what population do we really have the most data? Now, one consideration would be to take a more restrictive approach to really maximize the benefit risk ratio and minimize excess antibiotic use. However, that can make it more and more complex to identify who's a good candidate. Another consideration would be to take a broader approach, which is really, I think, an approach that can avoid stigma and can meet patient demand and potentially have a broader population level impact, but would mean using more antibiotics. So with those considerations, our interim guidelines, which will be revised as we have additional guidance coming out from CDC and other public health agencies, are to recommend DoxyPEP to those who would have qualified for the DoxyPEP study, with a particular focus on people with a history of syphilis, as that is the STI that causes the most morbidity. We also suggest that providers should offer DoxyPEP using shared decision-making to cis men, and trans women who've had multiple partners in the last year, even if they have not previously been diagnosed with an STI. And lastly, at this time, we are not recommending DoxyPEP for cis women based on the currently available evidence from the Kenya D-PEP study. So I really want to emphasize that counseling, high quality counseling is a critical component of patient-centered care and is a really important part of DoxyPEP implementation. The Institute of Medicine describes patient-centered care as care that is respectful and responsive to individual patient preferences, needs, and values. And I think that's what we all want in the field of sexual health as we take a sex positive and harm reduction approach to addressing our patients' preferences and needs. So what are some of these approaches to counseling patients about DoxyPEP? Well, first, again, important to utilize shared decision-making to support a patient's choice. It's important to guide our patients through a self-assessment of their own risk, to review what we know about the effectiveness of DoxyPEP and how it's used, and to acknowledge that there are unknowns around specifically the impact on the microbiome and the impact on antibiotic resistance in STIs and non-STI bacteria. And I think perhaps the most important point here is that we offer DoxyPEP as part of a comprehensive package of sexual health services. We have produced some materials that we use with our patients when counseling them about DoxyPEP, and they're available on the San Francisco City Clinic website. These are some screenshots of a handout broken up into 2 separate slides that really go through some of these key points. What is DoxyPEP? When should I take it? Again, this is 200 milligrams, ideally within 24 hours, but no later than 72 hours after condomless sex. We advise that people not take more than 200 milligrams within a 24-hour period. How should I take it? Just some of these key points: taking Doxy with a big glass of water, making sure people are aware of potential sun sensitivity, avoiding diversion or sharing of antibiotics, etc. We also, on our handout, review some of the unknowns that I've discussed, and of course, provide information about how our patients can reach us. We have a dosing guidance handout that's modeled after the handouts that were developed to explain to patients how to use 211 HIV PrEP, or event-driven HIV pre-exposure prophylaxis. We ensure that our patients have the opportunity to ask questions and get the information they desire before initiating DoxyPEP. Here again, you just see the overarching approach to this counseling, which, like all counseling, involves building rapport and trust, eliciting preferences, assisting the patient with a self-assessment of risk, offering enough detail to inform their decision-making, and making sure they know that they can always revisit the decision and make follow-up plans. As I've noted, DoxyPEP really should be offered as part of a comprehensive package of sexual health services. This is just one tool in our toolkit. And you can see here, there's so many other pieces to this, with primary prevention, vaccines, HIV, pre and post-exposure prophylaxis, engagement and care for people living with HIV, STI screening, partner services, and then of course, really probably the most impactful things we can do are address social determinants of health and ensure we have policy that supports LGBTQ rights, reproductive rights, and criminal justice reform, among many. So in early November 2022, we did begin offering DoxyPEP at our municipal sexual health clinic in San Francisco, SF City Clinic. Our STI clinic is a high volume clinic. We serve a diverse population, with about 50% of our patients being LGBTQ, and we offer a range of integrated services here at the clinic. And so our goal was, as the study has been winding down, was to really implement this intervention into our routine services. So I'm going to just share a couple of points about how the program works here at City Clinic. These address some of the questions I typically get as people are thinking about how to offer DoxyPEP in their settings. So again, we're a municipal STI clinic. We see all patients, regardless of their insurance status or ability to pay. And like our HIV PrEP program, our DoxyPEP program is open to patients with any insurance. However, there are certain insurers like Kaiser and the VA where patients need to go to their own providers to get a prescription. So we generally are connecting patients in those systems of care back to their medical home. Our program is status neutral, so it's open to patients both living with HIV and patients who are HIV negative. We do have people see a clinician at the time of DoxyPEP initiation. We are e-prescribing doxycycline for patients with insurance. And for those who are uninsured, we are directly dispensing doxycycline in clinic. As we thought about how much Doxy to dispense, this is a big topic that I'm also often asked about. We thought through this based on the data from the DoxyPEP study and wanted to to ensure that most patients had enough doxycycline to last 3 months to prevent folks from having to come in too frequently. And so as our initial program rolled out, we have been dispensing enough to cover so it was 60 to 100 pills, which covers 30 to 50 sexual episodes. Our plan at this time is to get liver function tests annually in our patients in the program. Our biomedical HIV prevention team under the leadership of Montika Levy has been absolutely essential in supporting this program. Our PrEP navigators meet with patients who are starting DoxyPEP to help determine their coverage. They work in the electronic health record in conjunction with our providers. They provide education, information, and counseling, and they talk with our patients at follow-up visits to collect information on risk behaviors and adherence. These are data that Dr. Oliver Bacon has been analyzing, and really at this point just go through January, but as of that date, we had initiated 312 people at the clinic on DoxyPEP, and since then have initiated about another 500. So there has been a lot of interest amongst our patients in using DoxyPEP. And you can see here some of the demographic and sexual behaviors of the folks who've been starting DoxyPEP. 94% have been MSM, 4% trans women, and 48% reported 2 to 5 sex partners in the prior 3 months, 40% 6 or more partners in the prior 3 months. A little over a third had a bacterial STI in the last year. So you can see that this population is a bit broader than those who were enrolled in the DoxyPEP study. And the racial ethnic characteristics of the folks initiating DoxyPEP really mirrors that of our HIV PrEP program, which is about 37% white, 31% Hispanic, 15% Asian or Pacific Islander, and 6% Black. So in this early phase, we are not seeing differential uptake based on racial or ethnic group in our initial early adopters, many of whom are in our HIV PrEP program. Some of the things that we're seeing in early implementation are that many patients do have questions around the dosing, and at follow-up visits, we realize, okay, we're still not entirely clear on how the dosing differs from 211 PrEP or daily PrEP. So I think really making sure people understand, taking it ideally within 24 hours, up to 72 hours after a specific episode of sex. It's really important to try to, hear from your patients, make sure they understand that. I think we're likely, on average, dispensing more Doxy than most people are needing. Most of our patients at this point in time are not needing refills at their first quarterly continuation visit. And most are reporting that they took the Doxy 0 to 5 times in the prior 3 months. So we do think that patients are reporting some selective use, not necessarily using it with all partners or all types of episodes. And that may be a bit different than how it was used in the studies. So whether the real world effectiveness will be maintained or be similar to the trial effectiveness, I think that still remains to be seen, and we'll have to keep an eye on that. One of the common clinical questions that we receive is how to manage contacts to an STI. In the field of sexual health, as many of you know, we have a principle that when someone comes in and they tell you you are a contact to an STI, go ahead and treat them right there at the same time as you test them, because we know that the likelihood that they're positive is pretty high, and we don't want to have people fall through the cracks. We want people to get treated promptly. Now, in the context of DoxyPEP, the likelihood that they're going to have an STI is much lower. And so from the antibiotic stewardship perspective, we are recommending to our patients who are on DoxyPEP that they defer treatment for gonorrhea, chlamydia until the test results are back. We are, however, continuing to empirically treat syphilis contacts who are on DoxyPEP. What are some next steps for DoxyPEP implementation? Well, I think many in the field are eagerly awaiting guidelines from CDC and other public health agencies, which will be critical for supporting safe and equitable access. As I've discussed during this webinar, there are still many important questions around how to best implement DoxyPEP, and we do need more research in this area to assess interest, uptake, community engagement, social marketing strategies, and provider education like we're doing today. We need longer term follow-up to better understand impacts on individual health, microbiome, and antimicrobial resistance. And we think that modeling studies will also be really helpful to assess the potential impact on STI incidence in the US. Certainly, sexual health clinics are one of the key players in this work, as well as all the other points of care, from primary care to CBOs to all kinds of pharmacies, all types of places where our patients receive sexual health services that need support to do this work. And then lastly, I know I didn't have a lot of time to talk about the vaccine, but certainly the meninge B vaccine is very promising, and we definitely need more federal funding to support basic science and clinical trial research into vaccines for STIs. I think in health departments and clinicians across the country are starting to think about how to implement in their settings, and convening local stakeholders is an important part of that process to discuss and address concerns, to identify potential champions and early adopters, to ensure that we have equitable access to DoxyPEP. We do think it's important that there's funds to cover the costs, which again is very minimal for those who are uninsured, to think about pilot programs in key settings, and again, to build capacity amongst our providers who end up becoming such important players in the rollout of any new intervention. I want to acknowledge and thank so many people who we have been working with on DoxyPEP research and rollout, from, first of all of the study participants, both in the US and internationally, the study teams, our biomedical HIV prevention team, our clinicians and clinical leaders, as well as many investigators, including Jean-Michel Molina from DoxyVac, Janelle Stewart from Kenya D-PEP study, and Colleen Kelly, who's been leading a lot of the microbiome work. So thank you again to the CalPTC for the opportunity to present. And I think Dr. Johnson is going to help lead us in a Q&A.
Yes, I am. Thank you so much, Dr. Cohen, for this very informative, very detailed, and very expert talk. Would you mind letting me share my screen, because there's one piece of breaking news that I am also hoping to share on the DoxyPEP front. Thank you. Give me 1 second, folks. Great. Okay, so my breaking news on the DoxyPEP front is that the California Department of Public Health actually just today released their own recommendations around DoxyPEP implementation in the state of California. So I just wanted to show this to you. Again, this is just posted today. The link is down at the bottom of the slide. California, the state, chose to follow sort of a similar tiered structure to what San Francisco is recommending as well. So tier 1, kind of here up the top, was to recommend DoxyPEP to MSM or transgender women who've had 1 or more bacterial STIs in the last 12 months. And then to offer DoxyPEP using shared or supported decision-making to all non-pregnant individuals who are at increased risk for bacterial STIs, as well as to those requesting DoxyPEP. There is a caveat there, at least a footnote, that there are populations where we're lacking data, such as transgender men, and populations like cisgender women, where so far the data suggests that this intervention was not effective from what we know so far. And then the third sort of recommendation or consideration from California Department of Public Health is, like San Francisco was saying, to provide comprehensive preventative sexual health counseling and education to all sexually active individuals, including the components that you see on this slide. So I just wanted to let you all know, again, this is new sort of breaking information just from today. So there you go. I am also going to just pull up our CME requirements. As a reminder, we do get a lot of questions about this, so we just want to have them up there for you if you do have questions about this, for something to refer to while we go through our Q&A. So, Dr. Cohen, thank you again for being here. It was such a privilege to have you. There are a lot of questions in the chat. We will get through as many of them as we can. I'm just going to start off with one theme that I was noticing in the chat, which is I felt that there was some desire to know more about the approach of PEP versus PrEP in the doxycycline world, and how those two approaches might differ, and whether we have any data for the pre-exposure prophylaxis approach.
Thank you. Great question. So there was one very early study of doxycycline conducted in LA that looked at the PrEP approach, so daily doxycycline to prevent STIs. That study enrolled quite a small number, I think it was maybe 30 people, and did show that daily doxy as pre-exposure prophylaxis significantly reduced bacterial STIs. Even though the study was small, it was actually surprising because it was not powered to show efficacy, but it actually did show efficacy. That said, I think that in the interest of antimicrobial stewardship, the PEP approach is favored in that you can really titrate the amount of doxycycline that you're taking to the amount of sex that you're having. So for people who are not having daily sex, they're able to take quite a bit less doxycycline. But if you are having daily sex, then maybe you would end up taking it as frequently as someone if the strategy were PrEP. There are a few other ongoing studies of doxycycline to prevent STIs, and I believe at least one of those does have a PrEP arm. So we'll have additional data on the various approaches over the coming years.
Thank you. I think that's just helpful context for folks to consider those two different approaches a little bit differently, and to clarify that what you were talking about today was mostly the post-exposure prophylaxis, after sex approach, which potentially has benefits for antimicrobial stewardship if people aren't having sex every day. Okay, next question. There were a couple of questions about this too. Basically wanting to know about the sites of exposure and whether you have data on doxyPEP efficacy from the doxyPEP study about site of exposure and whether there were any differences in preventative effects.
Yes, thanks. It's a great question. And we have done analyses looking at the protective benefit of doxyPEP for rectal infections, pharyngeal infections, and urethral infections, and did find that doxyPEP was effective at preventing infections at all three of those anatomic sites. So there wasn't a stronger benefit necessarily at one anatomic site or the other, nor was there an anatomic site where it didn't work, right? So there certainly have been questions as, oh, maybe it won't work as well in the pharynx. We know that pharyngeal infections can be a bit harder to treat, and that the antibiotic penetration in the pharyngeal tissues may not be as good. But in fact, in the DoxyPEP study, we did see protection at all three anatomic sites.
That's great. And the reason that vaginal was not included in that study was because these were trans women, probably not a ton of vaginal sex going on. Correct?
Correct.
Perfect. Okay. Next question. Sorry, I'm going kind of fast, but I want to try to get through as many as we can before the end of the webinar. Next one is an antibiotic resistance question, asking about whether there's any data or comparisons looking at MRSA tetracycline resistance or the gut microbiome in people who are taking daily doxy for other conditions, say like acne or rosacea or those sorts of things. I'm not aware of any, so I'm curious if you have an answer to that question.
Good questions. So I think it's an important question because methicillin-resistant Staph aureus is really the most important pathogen that when we're thinking about staph, because it's MRSA is when we tend to turn to oral doxycycline for treatment. And I didn't include the slide on MRSA from the DoxyPEP study, but I will say that the prevalence of MRSA was actually pretty low, and there was not a change in tetracycline resistant MRSA in the DoxyPEP study. But I think the person asking this question is asking, well, what about from other contexts? We use Doxy for acne and other things. And there are some data from the derm literature that long-term use of doxycycline can increase the prevalence of doxycycline resistant Staph aureus in people who are colonized. So I think, again, I think it's not necessarily surprising that that would occur, but is it going to occur on a level that would have population level or individual level clinical significance? I think that's not clear.
Great, thank you. That was a much more thorough answer than what I could provide, and I appreciate that response. The next question, I think this is a good one, and it's actually not one that I've thought about too much. The requester is asking, were patients in DoxyPEP who were taking DoxyPEP more or perhaps less likely to experience symptoms of an STI if they did get an STI while they were taking DoxyPEP?
Yeah, I think that's a really great question. So just like we looked at the anatomic sites, we also looked at the protective benefit for symptomatic STIs separately from asymptomatic, because there's questions in the field around like the clinical importance of these asymptomatic STIs, and really what we care about symptomatic STIs, because that causes distress and pain and et cetera. And we did find that DoxyPEP significantly reduced the incidence of both symptomatic STIs and asymptomatic STIs. The question of if you got an STI and you were taking DoxyPEP, was it more likely to be asymptomatic? I don't have the answer right on my fingertips for that, but it did protect against both symptomatic and asymptomatic STIs.
Mm-hmm. It's a good question, though. I wonder if you can answer it from your data, whether people would be less symptomatic if they were on DoxyPEP.
Yes, we are actually planning to look at that, but I don't have the data readily available. I agree. It's really an interesting question.
Yeah, I'm going to ask another one about people who get STIs in the context of being on DoxyPEP. This question is there any indication that DoxyPEP is creating issues for folks with possible recent syphilis exposure or who have serofast titers in terms of making it more difficult to assess new infections or determine whether treatment is indicated? Basically, like, does DoxyPEP change syphilis titers, and will that matter for assessing for reinfections or new exposures?
Yeah, I think that's another $1 million question that is very difficult to answer with the data we have so far from the RCTs. I do think that interpretation of syphilis titers in people with a history of syphilis is already a very complicated task. And I'm sure many of you who are providers in the field of sexual health provide consultation to others on this topic. It can be difficult to differentiate a new versus old syphilis infection. Will DoxyPEP make that more difficult? Again, I think we don't know. We don't know. I think better diagnostics, than the century-old VDRL non-treponemal antibody test would be helpful, generally speaking. But yeah, I think more to come on that.
Yeah, it's a good question, though. Thank you for the response to it. I'm going to ask a couple of practical questions now that are coming in. This one, I know City Clinic has a navigation program, and that's super helpful, but there were several questions about billing and insurance and whether insurers, including Medi-Cal or any others, are currently covering DoxyPEP and how you code DoxyPEP, and whether insurers are pushing back on how much Doxy you're writing for, if it is 60 to 100 pills every 3 months. So just any thoughts on the insurance piece?
We have not encountered any denials. Any patient has come back and said, oh, my insurance didn't cover this. I think that Doxy is so inexpensive that I don't know, we haven't encountered it. We are coding this with Z20.2, which is contact to an STI, I believe, generally, so general Z20.2 code. So yeah, we haven't run into insurance issues. There is also another option if you're unable to directly dispense to an uninsured patient, or for some reason there is an insurance issue, there's the, oh my gosh, I'm blanking on the name, the coupons that, you can also download for your patient, and if they can have some money at all, they can buy it at the pharmacy for very inexpensive price.
Is it the GoodRx?
GoodRx, thank you.
Yeah. Thank you. All right, I'm going to skim through. I know we're running short on time. A couple of questions about how much doxyPEP you are giving to people with your implementation program, specifically like to what extent you're taking into account how much sex people say they're having. Like if somebody says, I only had sex 0 times or 5 times in the last 3 months, do you still give them 60 to 100 pills, or do you cut down on that? That's the question.
Yeah, no, that's a good question. We kind of, because we are a high volume clinic and we're very protocol driven, it's a little bit difficult to have super nuanced case by case approaches to things. And because we have a lot of standardized protocols by which our teams work. I think in a smaller setting, it's certainly reasonable to dispense to the patient based on a conversation about like how much they think they'll need. Another consideration is just some of the practicalities, like often an insurer that's more true with PrEP, but for our bulk purchasing that we do, it's cheaper for us to buy 100 pills than 90 pills. I don't know, there are just some little practical considerations that went into that. I do think based on our early experience, we may reconsider the amount we're dispensing and decrease it a bit, just because we're not finding that people are using that volume. And there are some downsides to having excess antibiotics out there. They might expire, there's waste, there's sharing. So I think it's hard to find the sweet spot, but having it be tailored to the individual, if feasible in your setting, I think that's a great approach.
Thanks. So it sounds like some flexibility both on your all's end as you're implementing this, and that you think it would be reasonable to take patient report of their sexual behaviors into account. Makes sense. I'm also getting some questions to bring back the CDPH recommendation so that folks can see the link down at the bottom. So I've switched back to that slide to pull it up. Yeah, let me see if I can also put it in the chat, but I'm going to give Dr. Cohen another question first. Let me just pick a good one. This is sort of an opinion question, but let's say somebody has frequent sexual exposures and they end up taking doxycycline like daily or near daily. Do you think there's any guidance on how much is too much, or would you ever recommend that somebody scale back? Or is your feeling that Doxy is safe, people take it for other things for long periods of time, and so not really something we need to worry about?
I think that's a really difficult question, actually. I think we don't have enough data to answer that at this point in time. In the acne derm world, there is a move towards limiting the duration of use. But again, I think it would really depend on the patient and their level of exposure and their own STI history and how they're also doing with the Doxy themselves. Yeah. But yeah, I feel like we have enough data to say it's absolutely fine to take Doxy daily, for 10 years. Like we don't know.
Yeah. Fair enough, and I guess that's the purpose of the implementation science behind all of this. Just want to let folks know I'm having trouble pulling up my website browser to find this link while I'm also moderating the Q&A. So we can send it out with the materials for this webinar. And again, the link is down here at the bottom if you want to type it in to the CDPH new DoxyPEP guidance. All right, next question for you, Dr. Cohen, in our last couple minutes. Any data on DoxyPEP efficacy or effectiveness for LGV prevention?
We had, I think, only one, maybe two LGV cases in the DoxyPEP study. So it's just too small numbers to answer that question. Yeah, I mean, my hypothesis is that it would be effective for LGV prevention, because I think if you're taking the doxycycline within 24 hours of exposure to LGV, it's likely you're going to have enough antibiotic there to prevent the infection from being established. Really, the challenge with LGV is once the infection is established, because this is an invasive strain, it can be very inflammatory, and there's, more difficult to treat, takes a longer time to treat. And we know that there's some data that asymptomatic LGV responds to, shorter courses of doxy as well. But I think we don't know for sure.
Yeah, makes sense. And it's just not as common as an infection, so probably a little bit harder to gather data on that particular infection, but it's a good question.
Mm-hmm.
All right, next question. If DoxyPEP becomes a best practice, are you concerned for a low supply or shortage like what we're experiencing currently with bicillin for syphilis?
Yeah, no, I think that's an important point, and we have run into doxy supply issues even, in the last few years without DoxyPEP being widely used. I think there's a number of challenges related to supply chain and medication shortages, like broadly speaking, that have to be addressed at the federal level, and that are pretty complex. So I think that, on the positive side, there's a number of different manufacturers, whereas with bicillin, we're really limited to one manufacturer, which amplifies supply chain and availability issues with bicillin specifically. But yeah, I think it's just generally a concern in our healthcare system right now.
Yeah, I think that is a fair question. We are 1 minute left. I'm just going to see if there's any last burning questions. There were some questions about the D-PEP study in Kenya and whether, you have like personal opinions or thoughts as to why the study showed DoxyPEP to not be effective in cisgender women, and whether any ongoing studies might be looking at this to your knowledge. And I'll make that the last question.
Yeah, no, I'm really glad that's the last question, because I think that is finding a highly effective STI prevention tool for cis women is absolutely critical for our field. And these results were sobering. I don't know. I mean, I think there's from the HIV PrEP early studies, adherence was a big challenge in the early studies. And I think there's many who think, well, probably it was adherence. It should work. But, I don't know. I've spoken with the investigators from the D-PEP study. Their participants self-reported high levels of adherence. They, of course, the investigators feel like their participants took the meds, but they, I think they're concerned that it may not have been adherence. So I think we need more data, and I do hope there will be additional studies to help answer this really important question.
Yeah, me too, for sure. I feel like one of the sort of counter arguments, I guess, to the adherence question that I've heard, at least, and that was at Croy, basically, was the idea that, well, these women were on HIV pre-exposure prophylaxis and they didn't get HIV, even though something like a third of them were having transactional sex and they had multiple sex partners. So you would think they must have been taking their HIV pre-exposure prophylaxis. So like, these are adherent people. Why would they not take their DoxyPEP? But I think we don't know if there's something different about the two interventions that might make them more or less acceptable.
I agree.
Anyways, okay. I want to thank you again, Dr. Cohen. We are at time. I want to thank everybody for attending this webinar today, for all of your questions in the chat. We got through many, many of them. I'm sorry if we didn't get to your questions. We will send out the link to the CDPH guidelines as well as the materials from this webinar today. And we'll stop there. Thanks, everybody.
Thank you so much, Dr. Johnson. It was a pleasure.
Thank you.